Okay, we're going live. 5, 4, 3.
Good evening, everybody. Welcome to our weekly Skull Base and Cerebrovascular University of Miami Symposium. Again, a wonderful session awaits all of us tonight. This is our session number 21. It's October 8, 2020 today. I'm Jacques Morcos, professor and co-chair of neurosurgery and ENT, director of cerebrovascular and skull-based surgery at the University of Miami. Co-directors of this weekly symposium have been and continue to be my partners. Carolina Benjamin, assistant professor, directs our Keynes dissection lab, and she specializes in skull base and at the University of Miami and Jackson North Hospital. Mike Ivan, director of research at the Brain Tumor Initiative, and Mike specializes in brain tumors, skull base, and epilepsy surgery, as well as my two endovascular, open vascular partners, Bobby Stark and Eric Peterson. This is wonderful Miami. Our two centers of hospitals at our University of Miami Hospital and Jackson Memorial Hospital. Some housekeeping instructions for tonight. Audience members, use the Q&A box to send in your questions at any time throughout the lectures, and we will address them at the end of the speakers and the panelists' presentations. We don't offer CMEs. Share, please, the links with your colleagues in social media for this session and future sessions. I don't think I'll need to, but I'll alert and remind my speakers at 25 minutes. I'll give them a 2-minute warning to keep us all on time. Any of you in the audience who have specific suggestions for topics in cerebrovascular and skull base, or specific speakers you want us to consider, email me or follow me on Twitter. I'll give you a teaser of what's happening next week. It's a fantastic feast of neuroanatomy. You can see the 5 speakers we have for next Thursday and the colorful lecture titles they'll be giving. Any of you interested in applied neuroanatomy, I encourage you to join us next Thursday. Dr. Ribas, Dr. Tsu, Jeff Sorensen, Juan Carlos Fernandez Miranda, and Maria Perez-Celda. Next Wednesday, parallel to this Thursday weekly session, we have sessions every Wednesday that Mike Ivan, my partner, has been directing also for many months. And next Wednesday we have the pleasure of having Mark Suedan from Cornell talk about diffuse intrinsic pontine glioma. That's a series of Miami Global Brain Tumor Symposium. Please join us as well next Wednesday. Many thanks to the team that makes it happen, Ingrid, Roberto, Christina, and particularly Ignacio, who runs this seminar for us weekly. Various links for the audience members to connect with our department, to perhaps watch any of the any of the sessions that we've already recorded. that you can find them all on our YouTube channel, and many other things. Today is a special session. Really, it's a special session on orbit and for the neurosurgeon. And why the orbit? Well, we all know the orbit is a nexus of different subspecialties. And it is extremely relevant to neurosurgery, as I hope you will appreciate by the end of today. So first, let me introduce our wonderful panelists. We have three panelists. Kenan Arnautovic, a good friend for many years, is professor of neurosurgery at Semmes Murphey Clinic and Department of Neurosurgery, University of Tennessee Health Science Center, Memphis, Tennessee. Kenan has an extensive practice, particularly in skull base and brain tumor, and I'm delighted he could join us today. Garni Barkhudarian is co-director of the Pituitary Disorder Center, director of Adult Hydrocephalus Center, of the Facial Center Radiosurgery Program at the Pacific Neuroscience Institute at John Wayne Center in LA. Again, Garni is an accomplished skull-base surgeon and has significant experience in orbital and periorbital surgery, and he's joining our panel. Last but not least, my colleague of 25 years now, David C., here professor of ophthalmology. He is a Dr. Nasser Ibrahim Al-Rashid Chair of Ophthalmology. He specializes in eyelids, lacrimal, and orbital diseases at the world-famous Bascom Palmer Eye Institute, which is part of the University of Miami. And David has, of course, extensive experience with orbital surgery, with or without the assistance of neurosurgery, and his perspective will be priceless tonight. Now on to our two speakers. Let me start with Karl Heinemann. Karl is chair and professor of neurosurgery at Tufts. He was born, I don't know where exactly, but it's said outside Pittsburgh, Pennsylvania. Maybe he can tell us exactly what that means. Undergrad at Allegheny College, magna cum laude. His MD was at UPenn, residency at Tufts, fellowship at University of Tennessee in Memphis. You can see the influences in his life, really Bill Schuchart at Tufts and John Robertson from Memphis. He joins Tufts again and then became chair 15 years ago. Karl is world expert of pituitary skull-base surgery. Also has some other interests. He has 11 patents, including an endovascular device to probably revolutionize the treatment of hydrocephalus. That requires a whole different lecture all unto itself, perhaps another time. Karl has been, of course, very heavily involved in organized national and international neurosurgery. He's past president of NESBS, the Society of Neurosurgeons, or University Neurosurgeons, the Boston Society of Neurology and Psychiatry, the New England Society of Neurosurgery. And he, of course, is the chair of American Board of Neurological Surgery, currently after 6 long years of being on the board. And my hat to him for all the superb work that they do there. So that was Karl. On to Bill Caldwell, another wonderful friend of mine for many years, professor and chair of the Department of Neurosurgery at the University of Utah. Bill was born in British Columbia, Canada, undergrad at University of British Columbia in Vancouver and Dalhousie University in Halifax. MD, PhD at McGill in Montreal, residency at USC, where he came across these 3 gentlemen, and I know to various degrees they may have influenced his future career. Marty Weiss, Steve Gianotta, and Taka Fukushima. Did a fellowship at MNI in neuroimmunology and neurosurgery in Lausanne, joined USC again in 1991, became chair in Valhalla and New York Medical College from 97 to 2001, came to Utah now almost 20 years, amazingly. Time really flies by. 20 years has been chair. Bill has been past president of ANS, American Academy, International Meningioma Society, current president of World Academy of Neurosurgery, has been very involved with the JNS, editor-in-chief of the Neurosurgery Focus, was an ABNS director, vice president of the Senior Society, and many years ago was Wood Gold medalist and as a scholar at McGill in 1984, a very distinguished honor. Of course, Bill, no need to say it, but is a master of cerebrovascular and skull-based surgery, two disciplines that are really inseparable. So without further talking from me, I'm gonna stop, and Iggy, please stop my slides, and I invite Carl to share his slides, unmute his microphone, and talk to us. Thank you so much for all of you for coming.
All right, hopefully my slides are up. Can you see that, Jacques? And can you see my mouse?
Yes, everything working.
All right, well, thank you very much for having me. It's a true honor to participate, and looks like you've put together just, one great program after another. So congratulations on that. And what I thought I'd kind of focus on is sphenoid wing meningiomas and proptosis, and then throw a few vascular cases in the end. I don't have any conflicts of interest. But what I'd like to talk about is kind of en-plaque sphenoid wing meningiomas. And as most of our audience knows, meningiomas can grow kind of in a ball or globular type, but particularly unique to the sphenoid wing is the en-plaque meningioma type, where the meningioma tends to grow like sort of carpeting along the middle fossa, the orbit, and the temporalis fossa, and get into the bone. And just showing some examples of this. So here's 3 examples of right-sided en-plaque sphenoid wing meningiomas. Notice this enhancing tissue is meningioma. Meningioma is infiltrated through the bone, extending into the orbit. Very frequently, it comes right through the sphenoid wing bone and goes into the temporalis muscle. So you have to think about that. For example, look on this scan on the right. When you do this, usually the deep part of the temporalis muscle a lot of times has to go because it's infiltrated with meningioma. So you should keep that in mind with your reconstruction. 3 left-sided meningiomas, same concept, and the degree of hyperostosis varies by case, as does the degree to which the periorbital and lateral rectus muscle are invaded. One of the biggest problems I've had is thinking I got the whole tumor out, and then years later, some meningioma recurs in the lateral rectus muscle. Sometimes the plane is not as clear as you expect, like it might be in this case. Now, just looking at the coronal images, when you're looking at these scans pre-op, you want to keep in mind on this T1 fat sac coronal image, the extraocular muscles are quite bright. So this would be the lateral rectus muscle. This would be the superior rectus or levator, and the meningioma is extending through the bone right here. And so keep that in mind when you're looking at this. This is not all meningioma. You have to account for the extraocular muscles as well. And you can see how the orbital apex is frequently a site where the orbital contents are compressed and potentially the optic nerve. On CT scan, you have varying degrees of hyperostosis with this entity. It's really quite interesting how the meningioma invades through the bone and causes thickening of the bone. And a lot of times this can be misinterpreted by a radiologist as fibrous dysplasia. If someone sends you a case read as fibrous dysplasia, definitely you want to look at a gadolinium enhanced MRI and see if there's enhancement along the bone, along the dura, along the periorbita, because typically you don't see that with fibrous dysplasia. And so you can easily, at least in my experience, tell the difference. The bone can be quite thick, and this bone is infiltrated with meningioma in this case. Not in every single meningioma case, there's not always meningioma through the hyperostosis, but I think this is one where if you want to take all of this out, you really have to remove all of this abnormal bone. And that can be a challenge in cases like this where the whole skull base is involved, all the way down to the pterygoid plates here, extending into the sphenoid sinus. So this scan on the right, if I was going to think about operating on this case, I wouldn't necessarily remove all of this at one time. My goal would be to remove all of the tumor in the orbit down to the supraorbital fissure, drill the bone around rotundum, drill the bone around ovale, and a lot of times divide spinosum and drill the bone right up along, leaving a little bone along the glenoid fossa, trying to if possible, leave some bone over the temporomandibular joint. And then either follow this bone, the sphenoid sinus. I have on 2 occasions gone back endoscopic endonasal and drilled this out, but you still have probably meningioma infiltrated soft tissues between this component and this component if you do this in 2 stages. Now, I just point out this historical picture. It's really quite fascinating. This is in Cushing's book on meningioma. This is the 13 patients, 12 of the 13 patients he operated on, and every single one in this picture is a woman. And keep that in mind because there's much higher female predominance for these en plaque sphenoid wing meningiomas than there is with standard meningiomas. And if you look at these pictures, they're quite typical. The involved eye is pushed down and the soft tissues are puffy. The involved eye is pushed down and the soft tissues are puffy. The involved eye is pushed down, and really just kind of almost every one of these looks the same. This is the only one where you have to study for a little minute to figure out which side is the tumor on, but all the rest really look pretty much the same. And then I love this picture too. This was published by Joe Maroon and Kennerdell in Journal of Neurosurgery, 1994. And it's just a perfect picture showing the meningioma infiltrating and thickening the sphenoid wing bone. And you can see here the artist drew meningioma extending up right up to this point, and then normal bone marrow extending across the planum to this point, and then normal bone. And so if you study this on a pre-op case and you want to get all this out, of course, all this needs to go. And so so just kind of summarizing that, the meningioma grows carpet-like over the bone. The bone invasion is highly associated with hyperostosis. It's a small number of meningiomas, but 3 to 6 times more prevalent in women than in men, and very often presents with proptosis. So I've been interested in, how good have I done with the proptosis repair, because early in my career, I operated on a bunch of these and just was kind of disappointed that some of the patients still had a little bit of proptosis when they come back from clinic. And so I looked at, this is my series of my whole life. I have a database of every case I ever did. So I've done 637 meningiomas and 590 operations, 116 were sphenoid wing, down to 22 of them being these en plaque meningiomas, 3% overall. And again, a very high predominance of women, more than 4 to 1, at least in my series. And here would be just a typical picture in the OR here, another typical picture in the OR with very prominent periorbital. So how do you, track your proptosis and decide, are you doing the right thing? Are your patients looking like you want post-op? Of course, you could have an exophthalmometer, but usually not every case has these measurements pre-op that you can use. So I've evolved to use this index, which is called the Exophthalmics Index, which was published in 2009, where you can go back and look at your patients pre and post-op and see how you did. So you just draw a bone across the front of the lateral orbital wall, drop a perpendicular from the front of the eyeball, and if the eyeballs are in the same position, then A would equal B, and you would have a normal exophthalmos index. But if A is bigger than B, then you have exophthalmos, et cetera. And so you can go back, and as long as you have the scans, go back and look at this and then kind of analyze how you're doing so far. So if you take on one of these en plaque sphenoid wing meningiomas, your goals are to resect the tumor, correct the proptosis, and then, of course, if there's optic nerve compression, try to improve the vision. So what do you have to do with the orbital wall and the roof? You have to reconstruct them at all. Some people say, well, if the periorbit is intact, you don't have to reconstruct the orbital wall at all. But I'll show you what I like to do and what's the best way to accomplish this. And you need to compensate for fat necrosis or persistent edema. For example, when I was in fellowship, the oculoplastic surgeon in Memphis said, well, if you have a big compressive lesion filling the orbit, compressing the eye for a long time, you get some degree of fat necrosis, and there's less volume of fat in the orbit. So you should reconstruct maybe a little bit smaller than normal. Perhaps Dr. C could comment on that, but I've never found this to be the case. I never have seen in my life yet a fat necrosis or less orbital volume, even after very big tumors. So to me, if anything, I always seem to end up, if anything, having a little bit of persistent proptosis, not enophthalmos. I think enophthalmos is a problem if you're doing cancers and you're radiating to people, and then you have, retraction from the radiation. But if you're doing benign disease, it just doesn't seem to be a common problem. So this is what I usually do. Here would be, a frontotemporal incision, temporalis muscle taken down. Now you can see meningioma coming through the bone, and any involved temporalis muscle has to go. So I would remove that. And if you have to remove a lot of temporalis muscle, expect some atrophy here. So you want to reconstruct maybe a little proud if you take a lot of that. In some cases, I don't even do a craniotomy. I just start drilling then and just get out the drill and start drilling away this bone. Here's just another case. Again, you can see the meningioma coming through the bone. And so I'll just basically keep drilling away bone until I think I'm seeing normal dura. It's nice if you can save the orbital rim on these cases. It's just so much easier to reconstruct. And at least most of the en-plaque sphenoid wing meningiomas, the disease comes up the orbital roof and very often doesn't quite get to the orbital rim. So a lot of times you can just save that. So I would just start with drill and just keep drilling until, I don't think there's any more abnormal bone. And then usually what I do is then open the dura, resect the involved dura, patch it, and then do the periorbital last. And very often you can peel off the tumor with the periorbita and end up with something like this, where you have a patch dura, periorbita clean. Now, I've done this and thought I was clean, and then 5 years later, some meningioma recurred inside there. So you do have to follow these people, and it's a little harder to tell exactly where, potentially infiltrated meningioma has gone. Now, at this point, I've kind of gone to reconstructing the inner table with titanium mesh. So I kind of use plate benders to bend the mesh to mimic the inner table of the temporal lobe, the inner table where the frontal lobe would be, and then I try to reconstruct the orbit. But I always like to now kind of reconstruct the orbit maybe a little bigger than what I think it normally should have been. And that's not easy to do because you don't have the contralateral orbit to look at. You have just the one you're working on. But here would be another one, reconstructed the inner table. And then early in my career, I filled it in with methyl methacrylate just to kind of fill in that whole area. And then recently I've gone to using bone cement, hydroxyapatite bone cement. But you have to be careful when you first mix up, this is Hydrocet. When you mix up Hydrocet, sometimes it's a little bit liquid, and if you put it on early while it's still a little bit liquid, it can kind of flow through the mesh and end up encroaching on the orbit if you're not careful. Stryker came out with Hydrojet or Hydro-Inject, which is more viscous. As soon as you make it, it's less likely to flow. Just something to consider. But I tend to like the Hydrocet because it's easier to mold, easier to work with. But here would be like a typical pre-op scan showing the hyperostosis. Then the mesh with the hydroxyapatite cement kind of reconstructing the sphenoid wing there. So just want to discuss this issue again. Should you build an anatomically smaller orbit to compensate for chronic compression or tissue retraction, or build an anatomically normal or slightly larger orbit? So I had one of my residents look back to 2007, just finding all the cases where we had pre and post-op films so we could look at this and then measure that exophthalmos index to see if we could tell, whether we're ending up with good results or not. And we found 23 patients. Not everyone had a sphenoid wing meningioma, but 19 were meningiomas. Some just infiltrated into the orbit, and then a couple other pathologies. And basically, we used a computer program, and he just had some people measure the orbital volume. Doesn't look to me like these lines are perfectly straight, but that's what the residents generated. In any case, you can then compare how you did. This is just measuring pre and post-op on the contralateral normal orbit. Were they consistent in their measurements? And at least this shows that the residents I had measuring these orbital volumes were consistent pre and post-op on the same imaging. But what I found was that my average post-op exophthalmos index was still a little over 1.07. So we tended to have a little bit more exophthalmos, but the reduction was 0.2. So a decent reduction in how much exophthalmos there was, but not quite to 1.0. Now, compared to the contralateral orbit, 7 were pretty much exactly the same size, 15 were a little bit larger, 1 was a little smaller. And this was kind of with my strategy of always making the orbit a little bit bigger. So I wasn't perfect. Compared to the pathological orbit, usually they were bigger, but sometimes about the same. These were usually people with kind of small meningiomas. But this is the interesting slide. If you look at everyone who had residual proptosis, every one of these patients had meningioma invasion in the superorbital fissure. And so I think what's happening is, even though the orbital volume is pretty good, there's meningioma in the supraorbital fissure, so the supraophthalmic vein is blocked or doesn't exist or doesn't drain. And so there may be some kind of, residual, either venous drainage issue or venous hyper, or just something to make the orbital tissues a little bit puffy. And also, every patient who didn't have orbital fissure invasion by tumor had excellent proptosis correction. So I just point this out. If you're looking at pre-op films and you see, well, I'm not going to cut out their superior orbital fissure, obviously. I'm not going to take out cranial nerves V1, 6, and 3, etc. And meningioma is invading that area. Just know that at least those people tend to have more residual proptosis than other patients. So if you don't have that condition, it seems like the proptosis correction is great every time. And just some examples, you can see this is a post-op reconstruction. You can see the orbital wall is just a little bit wider than the other side, yet the eye position is pretty good. Here, the orbital reconstruction is a little wider than the other side, and the eye position is pretty good. A couple more examples on the left side. Here, the orbit is reconstructed just a little bit bigger. Eye position is good. So, I've kind of evolved to liking to have a little bit bigger lateral orbital wall reconstruction. And if I see supraophthalmic vein invasion, then I'll do even a little bit more. And I just want to end, because this is a vascular conference too, I just want to show two cases that have to do with proptosis, but not sphenoid wing, but maybe people will find this interesting. It's kind of a historical case, and that is surgery for indirect CC fistulas that cause proptosis. When I was a resident, John Robertson told me about the days before endovascular surgery, and when people had indirect CC fistulas, how he had to operate on them, pack the cavernous sinus with muscle. They'd have complete ophthalmoplegia for 3 to 4 months, but then that would go away and their fistula would be gone. And so recently I just had a couple of cases where we couldn't figure out an endovascular solution, so did a direct surgical repair, and after that, I'll turn it over to Bill Caldwell. Now here's a angiogram that shows fistula in this location. There's no posterior venous drainage. The inferior petrosal sinus is closed off, drains purely through the orbit, but yet there's a super tight stenosis in the supraorbital fissure. So if you look here, this is so tight, we didn't think we could do a cut down and get a catheter in and come and treat this through the orbit. And Adel Malik tried to get up there from behind, tried to get up there from the contralateral side, could never get a catheter there. So what are you going to do about this? So my strategy was, well, here's supraorbital fissure, here's foramen rotundum. I'm just going to cut down to this site, open this up, and pack muscle all the way back to this site, crushed muscle, like they did years ago. So just to show a video of this, so this is just positioning in the OR, frontotemporal scalp flap, doing a subtemporalis fascia, just to save the frontalis branch of the facial nerve. So just basically pulling that the flap forward. And then we're going to ultimately just drill down the sphenoid wing bone, find the anterior medial triangle between the supraorbital fissure and V2, and then open up that space, basically find the draining vein and basically pack it back towards the site of the fistula. Remember, it's interesting with endoscopic endonasal surgery, crushed muscle is kind of shown up as the best way to stop bleeding from the carotid if you get a hole in the carotid during endoscopic endonasal surgery. So I figured, a little crushed temporalis muscle maybe be a good way to close this fistula. It probably would be easier than trying to do something in the OR, put a catheter in and feed, feed wires, feed coils back. So you're just drilling down the sphenoid wing, getting the last little bit over the periorbita. Finding basically the inferior aspect of the supraorbital fissure, and now here using a Doppler, just mapping out the exact location of this arterialized vein. So here's the anterior medial triangle. So I'm going to open up into here and basically start packing. This is muscle that we crushed, which I'm sure is rich in calcium and a few other things, and just packing it back deep through this triangle. And you'll see how much muscle we just kept sliding muscle fibers back in. Until,
Carl, for the audience, show them where V2 is so they get oriented.
Okay, so V2 was coming right here out into foramen rotundum. and the supraorbital fissure was coming right here out to the orbit. So this is the periorbita, and now we see V2. So this is V2. This would be the anterior medial triangle. And I'm checking with the Doppler, and the fissure wasn't quite dead yet. So some more muscle goes in, and I was packing it medial to the nerves and inferior to the cavernous carotid. So I wasn't really worried about compressing anything. But as I slid it back, I kept adding a little more muscle in. And to me, it's better if you know the triangles and you know where the empty spaces are in the cavernous sinus. You can keep packing it this way without squishing a nerve or occluding the carotid, etc. So this looks like a lot of muscle, but it's basically a strip of temporalis muscle I cut up into 8 or 9 pieces and then squeezed with a snap and pushed it in. Put a little kitchen sink in there, some Surgicel, then some thrombin on some gel foam. And then I decided, you know what, I can fit a little more muscle in here. So I pushed it back a little more and put a little more muscle in. Then I didn't want this to move out post-op, so I just put a little stitch in just so it couldn't move. And here, just checking with the Doppler, and the fissure was gone. So I didn't have to open up the orbit. I didn't have to find that vein and coagulate it. I just put this little stitch in just so that those muscle grafts couldn't move out, essentially. So here's just on the right, you can see the pre-op with the fistula draining into the orbit, and then the post-op scan. And just the last case is the same idea, but a fistula in a different location. This is by the posterior clinoid process. The posterior drainage had clotted off or closed off somehow. And now the fistula was draining by tiny little things to the orbit, yet the patient's intraocular pressures were going up and she was losing vision. Here, Adel was trying to get through the inferior petrosal sinus to the cavernous sinus and just could never get his catheters through. So in this case, I knew that, okay, this is an axial image. Here's the carotid. Here's the vessels feeding this fistula and then draining into the orbit. This is the posterior medial part of the cavernous sinus, which you can get through the cavernous sinus roof, like you're going to drill off the posterior clinoid for a basilar. So here's the fistula site and the draining vein. And so here, I'm just this is a left-sided frontotemporal craniotomy, and here's, you can see, is the third nerve right here. So I'm opening, but I don't want to open all the way to the fourth nerve. So I'm just in this, supratrochlear triangle, just making a little room to get to the cavernous sinus roof. And I know the carotid artery is lateral to this, as are all the cranial nerves. So if I open a hole right here, I'm into that space where the fistula is. So I didn't want to make a giant hole. I wanted to make a small hole and make it big as I was pushing in muscle, etc. So here I'm just getting the hole started with some Surgicel. But then once I had a decent hole and some bleeding, then figured, okay, that's got to be the fistula site. Now I started packing muscle in there. And so basically did the same thing, crushed this muscle and packed it in and filled up the cavity where this fistula used to be. Tried not to push on the third nerve at all. And again, figured I could get another little piece in there. So, I don't know if this is going in the lumen of the vein or just compressing the vein, but probably a combination of both in the cavernous sinus. And then I just put a stitch, of course, across the top here, just so this couldn't leave as well. So just showing, just putting a little stitch in. I just didn't want to pop out post-op or anything. So I just put one stitch in just from the cavernous sinus edge over to the dura right over top of this, and then just tied it down. I figured that would just hold it in place. And so that was all. And then in this case here, you can see here's the fistula where it used to be located, and then post-op angiogram was gone. And this was just the Dyna CT, just showing the feeding vessels and the fistula vein, and then gone after packing it. So in summary, achieving a perfect orbit is challenging. During surgery for benign lesions like meningiomas, reconstruction, I think, to slightly larger than normal is probably the best way to go to present proptosis. I like to do it with mesh and bone cement, and post-op enophthalmos is quite rare. If tumors invading the supraorbital fissure, probably better to reconstruct the orbit even a little larger to allow for some of the soft tissue puffiness that you have post-op. And this exophthalmos index is a reliable way to look back at your results and do measurements and see how you're doing. So with that, I'll stop there, and I turn it back to you, Jacques.
Great, Carl. Fantastic. Yeah, I'm sure we'll leave many questions for the discussion. We'll keep going, but this is excellent. Thank you. Bill, how about you go ahead, please unmute your microphone and share your slides.
Great, Jacques. Can you hear me?
Yes, very well. And your slides are in navigation mode, not in presentation mode.
Sure. Well, thank you very much. It's an honor to be here, Jacques, and I really appreciate you asking me to speak. It's actually perfect that Carl spoke because I can delete the stuff that's duplicative. But I'd like to talk about our experience with orbital surgery. This is the University of Utah. And I just show you this as an example because this is a woman that went blind for 2 years up in Montana, and she was aversive to physicians. And she came down in extremis. And this just shows you the extent of disease that we see from the rural West here. This was actually an adenoid cystic carcinoma, and we removed this to save her life, and then removed the posterior fossa tumor. But the point of the slide is that we have little evidence basis for what we do. So most of it's iterative knowledge that's gained by experience in these unusual diseases. And so I think that skull-base surgeons must be familiar with the orbit. And I liken this to, a generation ago when Jacques and I were young, we were starting to do transnasal surgery. We did transsphenoidals, of course, but we extended the transsphenoidal and we became familiar with the sinuses. And I think this no-fly zone of the orbit is really a problem because it falls between two disciplines, and the surgeons need to be a little bit more familiar with the orbit and the anatomy. Al Roten has done some beautiful work, and Jeff Sorensen has annotated all these slides in his talks. And it's important to understand, for the young people, to understand the anatomy of the cranial nerves at the supraorbital fissure and into the orbit. Now, the orbit is fairly simple. The more complex area is this annulus region, supraorbital fissure, and the relationship of the nerves and how many of the nerves travel from lateral to medial as they cross over the optic nerve. So 4 crosses 3 at the supraorbital fissure and then goes here to the superior oblique. And V1 sends a frontal branch outside the annulus. And then of course the annulus carries the third division, which divides into 2 branches. And the upper branch is the important one when we're operating in the back of the orbit because it supplies the levator and the superior rectus. So it's important to understand the bony anatomy as well. And it's beyond the scope of this talk, but when we think of the orbit, we think about diseases that occur in the orbit and then diseases that occur and involve the orbit secondarily from our neurosurgical diseases. And so you can think about cranial orbital and orbital cranial approaches. And the way I think of it is quite simply. So if I'm addressing pathology in the superior orbit and lateral orbit, I'll use a lateral orbitotomy or a transcranial orbitotomy through various bone flaps. You can use a superior orbital flap. You can use a frontotemporal flap of some sort, whether it's a terional or a mini terional or an OZ. And then to address all this different pathology, and we don't have time to discuss it, but if the disease is involving the inferior part of the orbit, these transfacial approaches and the medial orbit, these transfacial approaches are simple and they're a direct approach to where the pathology is because you really want to address it away and remove the pathology away from the optic nerve. Here's such an example. Here's an hemangioma of the orbit. Patient's going blind. There's a little bit of proptosis, as you can see on the scan. Optic nerves being compressed. And we'll do a simple transnasal approach. and combine the transnasal approach with the transmaxillary by removing the medial maxillary wall, and then combine this approach, transnasal, transmaxillary, to give you a beautiful view of the inferior part of the orbit. And so we're just removing the medial maxillary wall there. And now we've got the orbit exposed. And you can see here's the inferior medial part of the orbit. So we'll incise into the lesion. And then you find the margin of the lesion with the periorbital fat. And it's just like removing any other tumor in the brain, in that we come around, we debulk, and then we dissect the capsule of the tumor from the surrounding structures. And you can see here where we'll reduce it down to its attachment at its vascular pedicle, and then cut the pedicle and remove the lesion. Boom, there you go. And in this size of a defect, we won't reconstruct, but we'll just cover it up with some pledgets of gel foam. And you can see here his post-op scan that he's got reduction in his proptosis and improvement in his vision. So a fairly simple approach. The endoscope really helps it. This is an interesting case. This is one that we would choose a transcranial orbitotomy on. If you look here, he's got a schwannoma sitting on top of the optic nerve. So we'll come in with a frontotemporal flap, but come in superiorly, drill out the orbital roof, and identify the tumor. So there's the clinoid. And you really want to get a good exposure to find your best exposure into the tumor. So there's the levator. We're going to come just to the side of the levator and find the tumor. And then once we get into the tumor, we'll drain the tumor. This is partially cystic, it's a schwannoma. And then continue your dissection, just as you would do this in an intracranial case like an acoustic. We'll go ahead and debulk the tumor and then dissect it from its investment in the superior orbit. So we do this. This is, I think, was done with Alison Crum, one of our ophthalmic surgeons. But Bhupi Patel and I have done a lot of work together over the years. And then after removal of the tumor, we've decompressed him. And it's a simple matter to reconstruct the roof if you so wish. And I'll talk about that a little bit when we talk about meningiomas. So some of these schwannomas can be very complex. So here's a woman with a multicystic schwannoma extending on several divisions of the trigeminal nerve. And this is a unique syndrome where you see these discontinuous cystic schwannomas involving the orbit all the way back to the region of the cavernous sinus. We've had several cases. Sam Malmefty and I just published a series of these patients where they involve different segments of the nerve and they appear discontinuous, which is fascinating. So in a case like this, we'll do an orbital cranial approach and remove this and drill out over the orbit, and then expose the cavernous sinus and remove the tumor from the cavernous sinus and follow it right out to the region of the superior orbit along V1. So this is partially cystic tumor in the cavernous sinus that I'm removing. And then Bhupi and I will remove the tumor in the superior orbit here, and he's dissecting down on the roof of the orbit. Just following along V1 and these cystic components along the frontal branch and draining those and removing the solid portions of the tumor. So I'll just move on and just briefly mention sphenoorbital meningioma, which I think was covered so well by Carl. But this is the problem, of course. It's hyperostosis and involvement of the eye in the orbit. And you get this proptosis can be tremendous. We actually measure it from the extent of the entire orbit over the contralateral side, because then this really tells you the extent of the problem and how much the optic nerve is stretched. And we call it a proptosis index, but as was nicely described, it's a combination of bone and soft tissue, both in the orbit and in the cranial cavity, and as Carl mentioned, extracranial as well. So I have evolved a lot over the years with this. I started off being quite conservative when I was younger. And until about 15 years ago, I was very disappointed, as Carl mentioned, with the amount of proptosis improvement. So we started to do a very aggressive operation with these, where we've targeted removing all the involved bone. And as Carl mentioned, the rim often is not involved, which is great because you can just use that as a normal landmark and leave that intact, but take all of the hyperostotic bone behind it, involving the sphenoid ridge and the roof, and drilling it out, because the tumor that's thick in the bone is filled with tumor, and it will be a source of recurrence, as I'll show you in a moment. So you've seen cases such as this, very bad proptosis, and then you remove all the bone, including the middle fossa floor as necessary. I'll just show you how we deal with the orbit.
This patient is a 66-year-old woman with a profound right-sided proptosis from a large sphenoorbital lobe herniation.
You can see how bad the herniation is here. She's got temporal lobe
We
herniation.
took her urgently.
So
We've now removed the bone, the superior and the lateral orbit, and the superior orbital.
this is like archaeology. You're drilling for normal structures, and the bone is all thickened. Look at the size of the clinoid here. So we'll remove the clinoid. There's the optic nerve, very thickened clinoid, and drill out over the superorbital fissure. Then remove the tumor in the anterior cranial fossa and the middle fossa. And then we'll concentrate on the orbit. And how I like to do this is I get right behind the rim here, and I find the margin of the fat and the periorbita, because she's got a lot of soft tissue in the orbit itself. So we'll find the margin along the periorbital fat, be careful of the frontal branch, and then follow it back towards the apex of the orbit. Now you'll have to decide, because as Carl showed you, the tumor can merge and invade the lateral rectus, and you'll have to decide if you're going to take that. We'll try to leave that intact if we can, and we'll go right back to the annulus as necessary. Now, I've stopped reconstructing completely, and I'll tell you why, and I'll show you a graph why. But basically, it's because I was very unhappy with the amount of proptosis reduction. So after we close, you can see, look at the optic nerve now. It's like a road course, completely decompressed. So we'll take her back 2 weeks later, and this is this one with terrible proptosis, and I'll show you how much reduction she's had. We'll use a custom cranioplasty in this because we've removed all the bone, obviously, that's been hyperostotic. And go ahead, and you can see her eye now, and you can see the post-op 2 weeks after surgery, her eye is completely reduced. Now you'll say, well, she's just going to get in ophthalmos. And we looked at 38 patients that we'd done this way. And we looked at the proptosis index, and as Carl showed, it improves in everybody. But what it really does, and if you don't drill the bone, this is what happens. Here's an example. I've reported this case. I drilled the bone completely, and 7 years later, there's recurrence. So fascinating. So the bone is a source of recurrence. So this is the proptosis index on our patients, in those 38 patients, and the ones that we had good images. And you'll notice that it's not less than 1 in anybody. And so I've completely abandoned reconstructing the orbit, because I think this chronic, and Bhupi and I think that the chronic compression of the orbit with this terrible proptosis has changed the dynamics so much. And it may be the supraorbital fissure drainage, Carl. I mean, that's a good thought. But it inhibits them from getting enophthalmos. Just to remind you that it can be more than just tumors that compress the orbit. This is a case that we did, that he has a young man with meningioma, but he's got this pneumosinus dilatans. And this is something that when meningiomas grow next to the sinus, they cause blistering of the sinus. We've all seen this, but it can be a mass effect on its own. So you have to remove that. So the results suggest that aggressive surgical resection of meningioma-associated proptosis can result in significant proptosis improvement. And it's a bit of a guessing game to see how much decompression you need. but I tend to remove all the involved bone and then don't reconstruct. And I'm happy to entertain comments about that afterwards. So let's move on. And I just want to talk about an approach we've used more frequently for small lesions in the anterior cavernous sinus and superior orbital fissure. But if you look at the evolution of the frontotemporal approach, it was really popularized by Yasargil for anterior circulation aneurysms back in the 60s. And if you think about doing an approach where you're resecting these tumors that involve the orbit, what you realize is that there's a very short distance along the lateral orbital wall to the anterior cavernous sinus, one of the shortest distances to the cavernous carotid. And it's quite cosmetically acceptable. And so this is something that Bhupi and I published some years ago, but you can come along the lateral orbital wall, and this is a well-known ophthalmological approach, but you can take it farther back to the superior orbital fissure and into the middle fossa if you need to. So if you have disease at extent involving this area, you can chase it posteriorly. And we just use a little tiny bone flap along the lateral orbital rim, and then we go back and you can lift the dura up from the temporal tip and find the middle fossa, just like peeling the lateral wall of the cavernous sinus through a frontotemporal approach. And you can find all the structures of the cavernous sinus and get to the carotid artery as well. This is a cadaver, but I'll show you it in a video. The benefit is that you're coming underneath the temporalis, so you're not disconnecting the temporalis, and there's no brain retraction, and it's entirely extradural. But this is how it's done.
It's a 65-year-old woman
So this
with a history of
woman
progressive
has
painful.
a lesion of her left cavernous sinus. She had a bone marrow transplant, and the oncologists were worried that she had recurrence of her lesion. And you can see the anterior cavernous sinus and supraorbital fissures involved. So we'll do a biopsy this way. And you just come along with a lateral incision along the canthus. We like to extend the incision up into the eyelid and then identify the lateral orbital rim. 15 millimeters of the lateral orbital rim from the zygoma up. And then we take a little oscillating saw or a C1 bit so it doesn't take too much bone and remove the lateral orbital rim. We fit the plates before we remove the bone so we get perfect apposition. And then we'll go ahead and remove the lateral orbital rim and then just drill down the lateral orbital wall. And you can leave a thin shell the whole way down so you don't get any enophthalmos from decompressing the lateral orbital wall. And then you find the dura and you peel it up and you're right on the cavernous sinus. In this case, we found a lesion that was firm. It was obviously not a recurrence of her lymphoid problem or her leukemia. And this was a very unusual case. It was a smooth muscle tumor, probably the result of her bone marrow transplant. So there's no closure at the end. You're extradural. So we close the soft tissue after we put the lateral orbital rim back and merely close the skin in a cosmetic fashion. We use a subcuticular suture. So the whole operation takes about 30 to 40 minutes, and it's very simple. We send the patients home the next day. You can also decompress the optic nerve this way. If you have a meningioma, here I'm taking out the clinoid. This is a meningioma with visual loss. So we'll peel up the lateral wall of the cavernous sinus, remove the clinoid, and drill the canal.
See exposed the lateral aspect.
This is closure. We just use liquid gel foam for hemostasis and go ahead and close. So this is what you can achieve. This is the bony removal. The clinoid's gone. The optic canal is open. And this is his incision 6 months later. And you can see the temporalis muscle is completely intact. So a handy operation for small lesions of the superior orbital fissure and the cavernous sinus. It's limited exposure. I think we'll move on and talk. I just want to spend the last few minutes talking about this case. And I appreciate Dr. Say's comments on this. This is an interesting case of a young woman with an optic glioma. And I think it identifies the anatomy that's really important to the neurosurgeon at the orbital apex. And this is why I wanted to emphasize this. This is some of the beautiful slides of the rodent collection. The annulus of Zinn, you remember that the rectus muscles all attached to the annulus. And so we'll do a transcranial orbitotomy in this case, where we'll remove the roof of the orbit and then remove the optic nerve from the chiasm right up to the globe. Here's the frontal branch of the V1. Here's the fourth nerve running outside the annulus. Remember, 4 crosses 3 at the superorbital fissure, an important relationship, and then 4 crosses over the optic nerve just in front of the annulus. So there's 2 ways to do this. You can come lateral to the superior rectus or medial to the superior rectus. In this case, we'll show you we'll come medial. And then we'll dissect right up to the globe and cut the nerve at the globe. It's important to recognize the relationships of the nerves. As I said, a lot of them cross over the optic nerve. So when you do this operation, you need to be careful not to injure the nerves. The ones at risk are the fourth nerve, V1, and the upper division of the oculomotor nerve. So this is a MRI demonstrating a high signal intensity and contrast enhancement of the optic nerve. This was biopsied by Bupi. It was found to be low-grade glioma. And she was NLP in that eye. So we'll go ahead and do a resection for basically cure. This is a WHO grade 1 astrocytoma. So frontotemporal approach. And we'll go ahead and do a superior orbitotomy and remove the optic nerve from the chiasm to the globe. So we'll move this along. So frontotemporal, so we're going to go ahead and open up and drill the lateral orbital region, the superior orbital wall here, and also then we'll identify the periorbita. We unroof the optic canal and identify the optic nerve. We'll remove the clinoid and drill the lateral orbit just enough so that we can retract some of the contents of the orbit as we go and dissect out to the region of the globe. So once we've gone ahead and exposed the superior orbit enough, what we're going to be doing is lifting the optic nerve out from its investment, and we'll have to dissect it from the annulus as well. Now, the risk of this operation is to give the patient a third nerve palsy and a levator problem. So what we'll do, I'll show you how I deal with this. So there's the optic strut. Most neurosurgeons are familiar with this. We'll do a T-shaped opening down the Sylvian fissure and then across the roof of the orbit. Falciform ligament, and then we'll target about 2 millimeters anterior to the chiasm and we'll amputate the optic nerve. And we'll make sure the pathologist looks at that and make sure they're past the pathology of the glioma in that specimen. So we'll label the specimen accordingly. Now, what we'll do now is we'll dissect along the optic nerve. We're going to dissect right up to the annular ligament here. And you've got to be careful. We're going to come just medial to the levator. And we're going to be careful of V1, the frontal branch. And the upper division of the third nerve comes underneath the levator to innervate it. So you've got to be really careful with your retraction on this so you don't give the patient a ptosis post-op. So the fourth nerve crosses over the optic nerve just in front of the annulus there. And then we're on the optic nerve now, and we're going to march out the globe right out to the eye itself, and just continue dissecting. And the problem in this case is that you can see the nerve is very thickened, and it's all scarred in this area from the previous lateral orbitotomy and biopsy. But we'll continue to dissect around it. Use self-retaining retractors. Our neurosurgical retractors are perfect for this. And stay right on the optic nerve until you reach the globe. And then we'll amputate right at the globe. Now, what I find easier is I retract the distal end of the optic nerve now. We're going to remove this as one specimen. This is a little different than the way the ophthalmologists do it, I think, because they come in from the front. But you can remove this as one specimen. I'll show you how it's done. So the idea is that you have to dissect the nerve from its investment through the annulus. So I'll retract the cut nerve up now, and we'll dissect the nerve off the annulus. Be careful of the nasociliary nerve, the fourth nerve, and remove it as a specimen. And then we'll go ahead and basically repair the annulus and the periorbita. And in these cases, I do reconstruct the orbit, because you will give somebody enophthalmos, of course, because this is a completely normal orbit. And we'll go ahead. This is one of these MedPore implants with titanium. And then we got into the frontal sinus with our bone flap, so we'll just oversew that. And MedPore cranioplasty that I've used for 25 years. And that's the end of the operation. And I'll show you what she looks like at the end. So these patients end up often with a mild ptosis, but if you're careful with that retraction on the levator and the superior rectus, it will recover. So this is her post-op imaging. You can see the optic nerve's gone. She had a little bit of ptosis. She was discharged on post-op day 4. This is about 3 weeks after surgery, and now she's completely recovered of ptosis. So I think I'll leave it at that, with just one comment saying that I think that we should be more aggressive with these meningiomas of the lateral orbital wall. Here's a case in point. This patient underwent many operations and radiation over a 10 to 15 year period with recurrence, ultimately ended up with this recurrence in the orbit. It was never addressed, ended up having radiosurgery multiple times, and then is in this problem. And she's got tumor in her cavernous sinus, and you can see that she's got a she's got a prosthesis in her right eye. And we end up doing a complete resection of that area with a free flap. So she's in trouble. So I'll leave it with that and make you want to thank you very much. The conclusions are orbital surgery should be familiar. The orbit is generally a forgiving structure to operate upon. I find it more forgiving than the brain in general. It is important to know the anatomy, and it's a common area for tumor recurrence with meningioma, given it is not removed completely. Thank you very much.
Thanks, Bill, very much. You've given us lots of themes to perhaps discuss at the end, but that was a fantastic tour de force of the orbit from a neurosurgeon's perspective. Perhaps the best thing to do now is to ask David C., to give the few slides. And I think, David, if you can unmute your microphone and share your slides.
Okay.
Yeah, you had it a second ago. Yeah, just if you click on the...
Okay, got it.
Got it.
Can you see now?
Yes, David, thank you.
Well, thank you very much, Jacques, for inviting me to this meeting to be with an august group of neurosurgeons. I am very impressed with the presentation of both speakers, and in particular, Bill's innovative approach to the orbit. And certainly I glean a lot of pearls from listening to his approach from the neurosurgeon's perspective. I would like to share with you an orbital surgeon's perspective in gaining access to the orbital apex. I'm very fortunate to be able to work with a wonderful group of neurosurgery colleagues in this medical school. And they have provided us with wonderful access to the orbit from above. And so this is how I would approach it, and sharing many of the comments that Bill had made already. The superior orbital, cranial orbital approach, the indication that we use from an orbital surgeon standpoint would be to access lesions located in the apex too far to reach from an anterior or lateral orbitotomy approach, traditional route for the orbital surgeon to gain access to the lesion in that region. And also to access lesions in the extending into the cavernous sinus or optic canal, as in the case of optic nerve glioma. And I'm glad that Bill had presented a case of a glioma and outlines many of the surgical anatomies and cautions in reaching this area. So I do have a similar case of optic nerve glioma to illustrate some of these points. The complex regional anatomy of the orbital apex poses technical challenges for the surgeon and will require special considerations when removing lesions situated in this tight orbital space. The optic nerve is tightly adherent to the entrance of the optic canal and cannot be easily displaced like the segment of the optic nerve in the middle of the orbit. So traumatic optic neuropathy resulting in vision compromise can easily occur when manipulating a lesion wedged in the orbital apex. As an orbital surgeon, we're always mindful of the vision outcome in removing this mass. Equally important is the confluence of cranial nerves emerging from the superior orbital fissure that frequently will envelop the surface of a lesion, and certainly trauma to the superior branch of the third nerve can lead to permanent paralytic ptosis, a very disabling complication, particularly if the superior rectus is also affected. The guiding principle that I adhere to in accessing the apical lesions are that one should be mindful of the location of the optic nerve at all times relative to the lesion itself. And dissection of the lesion should always be in a unidirectional manner away from the optic nerve and toward the intracranial compartment vacated by the removal of the orbital roof. And dissection plane should always be along the surface of the lesion and carefully peel off the nerve fibers adhering to the tumor surface and then insulate them with a neurosurgical cottonoid while retracting it. Hemostasis obviously is an important aspect of it, as hematoma formation in this tight space will cause compressive optic neuropathy. I will illustrate these 2 points with a few cases here. First is a 4-year-old child with optic nerve glioma. And as you can see here, the typical appearance with enlargement taking up the space within the orbit. And there's an enlargement of the intracanalicular portion of the optic nerve. On sagittal view, you can see the enlargement of the intracanalicular portion and extending intracranially toward the chiasm. The indication we use for surgical resection of optic nerve glioma is when there is no vision, troubling, disfiguring proptosis with exposure keratopathy. It must have demonstrated growth of the chiasm on MRI. And then there's optic canal enlargement on CT scan, as indicated in here. And then the intracranial portion of the lesion is resectable. In the past, the conventional orbital approach, the orbital surgeon's approach, would be, like Bill has said, through an lateral orbitotomy, resecting or cutting, transecting the glioma from the back of the eye, and then dissecting back to the apex of the orbit. But the problem is you can never get a margin clearance, and much of the lesion will still be will retain within the annulus and also within the canal. In some cases, as this specimen illustrates, the surgeon would remove the eye along with the tumor as well. Now, the conventional neurosurgical approach, the Halcyon and block resection, is that the levator is incised longitudinally at its origin, medial to the superior rectus, and then the annulus is transected, and then finally the superior rectus and the superior branch of the third nerve are retracted laterally. The major complication of the Halcyon approach is a postoperative permanent paralytic ptosis, as you can see in this kid that had the tumor resected and then complicated by complete paralytic ptosis. The problem is that if you try to elevate this ptotic eyelid with a sling, the patient has an inability to bell because of the innervation to the superior rectus is also involved. So as a consequence, there is nocturnal exposure keratopathy, and it's very uncomfortable for the patient. So the problem is not just addressing the ptosis, but the problem is also how to address the inability to bell and move the eye superiorly. And so we have to be mindful of the complexity of the anatomy within the apex of the orbit. Always try to recognize where the superior branch of third nerve is a structure that we try to look for right away and protect it. Several years ago, John Rakob and I tried to overcome the shortcomings of the Halcyon approach, mainly permanent paralytic ptosis, is to try to find a way to bypass the incision or opening of the annulus of Zinn, and with injury to the superior branch of third nerve. So what we have done is through a transcranial approach, John would transect the intracranial portion of the optic nerve about 2 millimeters anterior to the chiasm, and then dissect and unroof the canal of the optic canal, and then resect the intracanalicular portion of the optic canal all the way to the back of the annulus of Zinn. And this segment is then submitted for intraoperative tumor margin surveillance. And this is a form of a Mohs excision to look at the cut edge of the margin, making sure that we have all the glioma resected. And the pathology would come back. You can see in here the arrow pointing to the presence of glioma anteriorly and negative posterior margin, as indicated by the asterisk in here. So there's intraoperative confirmation of the intracranial margin clearance. Now the case is then handed over to the orbital surgeon. This is the view after the roof has been removed. And I would make a inverted L-shaped incision on the paraorbita, gaining entrance into the orbit through the medial orbit between the superior oblique and the levator muscle. Try to enter the orbit medially, avoiding temporal entry because of the of the emergence of the nerve fibers coming out of the superior orbital fissure. And the key in here, for me, is to go immediately to the surface of the lesion. I use the surface, the capsule, the lesion, the surface of the lesion as my guide, and always hugging the surface and retracting it. And this way you avoid injuring any nerve fibers amidst traversing through the orbital fat. So this is a good path to follow, and also allows you to look for any nerve fibers that may be adherent to the surface that will permit you to dissect it freely, dissect it off freely, and then insulate it with neurosurgical cottonoid to protect that. The key in here is always trying to protect the superior branchial third nerve to avoid that postoperative ptosis in here. So you can see that this is the path of the traditional Halcyon dissection plane, cutting through the levator and then dissecting it temporally. And you can see that plane. And then the way that we do it is that follow the surface of the lesion, using that as a guide and not to venture outside of that. And the reason is that here's the superior branch of third nerve. So this way, it would allow us to retract the superior branchial third nerve laterally and insulate it with neurosurgical cottonoid. And this is the way to guide us to get through the entire lesion at all. So, and then we dissect the lesion anteriorly until we hit the back of the eye, and then the glioma is then transected from the back of the globe. You can see the hemostat holding at the cut end of the nerve that has been transected from the back of the globe. The key instrument to use is the enucleation snare, as you can see in here. So the globe is situated over here, and then by lifting up this glioma, we can go dissect the ventral surface of the glioma all the way to the apex of the orbit, and we do this circumferentially around the lesion, and then we introduce a snare all the way into the apex. And so this is the snare is advanced into the orbital apex between the optic nerve and the dural surface and the annulus. And you can see the snare is aiming deep into the orbit. The wire enveloping the back surface of the tumor is then slowly turned to narrowly to constrict the lesion, and then finally amputated at the apex of the orbit. All this while retracting the tissue without the instrument injuring the optic, without injuring the superior branchial third nerve. And so you can see now the finely turning of the snare to amputate the lesion. And this is what the lesion looks like. And here's the portion of the optic nerve in the annulus. Keep in mind, John had cut this portion of the optic nerve from intracranial space in here. So this is the lesion. This is the cut end from the back of the eye, and this is a portion that is within the annulus. It comes out as a unit, so without opening the annulus of sin, and then the periorbital is then closed, and then he would restore the craniotomy in the usual manner. So this is what the child looks like beforehand, and you can see the removal of the lesion. The key thing is the patient has full motility and there's no ptosis at all. And this is what he looks like after removal. Here's the same technique can be applied to adults using the same concept. And here's a patient with a recurrent optic nerve meningioma after 2 procedures and causing proptosis deviation but normal functioning eye, full motility, but a little bit of a proptosis. On this side, you can see the apex of the orbit is filled with this tumor. The main point that he wants is that he does not want to have postoperative ptosis. And so using the same technique, dissect the lesion, amputate this from the back of the eye, and then introducing the snare to the apex of the orbit after dissecting the lesion circumferentially on the ventral surface, medially and laterally, and then amputating it and block. And this is what he looks like after the procedure with full motility and no ptosis. That's a key element, and that is attention to preserving the superior branchial third nerve. Now there are, this is a picture from Rowton's book, and beautiful illustration, and just illustrating another lesion locating in this area abutting the optic nerves. So our priority would be to minimize trauma to the optic nerve. Keep in mind that the optic nerve is adherent to the entrance of the optic canal so that it does not move very well. And so the dissection of the lesion should be in a unidirectional manner away from the optic nerve to minimize trauma that will result in traumatic optic neuropathy. So here's a case that illustrates that. You can see the lesion is pressing the optic nerve medially, indenting the optic nerve, and this portion of the optic nerve is fixed, most vulnerable to pressure in here. It's already in a very tight space. The optic nerve has been displaced supranasally, so this is a very crowded area. So the dissection should be along this direction in here after the removal of the roof in here. So this would be the direction. It's always a unidirectional superior dissection away from the optic nerve, mindful of the need to preserve vision of the optic nerve. Now here's another lesion that on these views, we show that this lesion could be removed from an anterior approach or lateral orbitotomy approach. But if we look at this lesion closely on a sagittal view, this lesion is situated under the levator on top of the superior rectus. And this illustrates the location of the lesion. And we have to be mindful of the fact that the superior branchial third nerve comes in under this superior rectus, perforates the superior rectus, and then innervating the levator from the undersurface of the structure in here. So when we dissect posteriorly, we need to be careful about injuring the superior branchial third nerve. And so we need to have good exposure. And in this case, we were able to do it through the transcranial approach. And it was safely removed. Here's another lesion situated temporally and has an origin component of it in the maxillary sinus. And in this way, Jacques provided access to the temporal approach by burying out the greater wing of the sphenoid. And this is the view through his microscope, seeing the periorbital distending out, and underneath of it is the lesion distending outward after the removal of the bone. And upon manipulating the lesion, you can see material exuded out from the lesion, and this turns out to be a mucocele with the origin from the maxillary sinus. Very unusual presentation, presenting in the apex of the orbit. And you can see after evacuating the content, you can see the thick capsule in here. This was dissected intact with a unidirectional dissection motion away from the optic nerve, which is situated on the side of the orbit that the surgeon cannot see. So by following the capsule, we can then peel the lesion away from the optic nerve. So this is what the patient looks like before and after that, and from the lateral aspect of the lateral rectus. So in summary, by case illustration, I provided a few of the guiding principles that I adhere to when I try to remove lesions located in the orbital apex. And certainly many of the points that I made in here also emphasized by Bill as well. So thank you very much.
Thanks, David. That was great, kind of giving your perspective as an oculoplastic surgeon. I wonder if, before I move on to Keenan, if Bill or Carl have any comments or questions to David as an oculoplastic surgeon. If not, go ahead. Oh.
I was just going to say that's just beautiful illustration of many different approaches, and congratulations. That was awesome.
Yeah, I congratulations, and I've really enjoyed my working relationship with our ophthalmologists as well over the years. It's been a terrific, fruitful relationship.
Okay. Do you routinely open the annulus?
We do if it's necessary. I wanted to remove that specimen as one piece. And I wanted to see if you could just, so we actually opened just part of the annulus in that case, and then I sewed it back up. And we open it up just medial to where the superior rectus is, and just very carefully pull on the levator as you've emphasized. But you can dissect it out and just pull the whole thing out of the annulus that way.
Okay, Keenan, why don't we have you share your slides and show us a case and discuss with our speakers what you'd like them to say.
Okay, can you hear me?
Yeah.
We hear you and we see the slides in the navigation mode.
One second. All right. Thank you very much, Jacques. It's really an honor to be here with you, and it's really an honor to present after my people whom I learned a lot from, Professor Caldwell. Carl Hellman has been friend, and he has Memphis connections since he did his fellowship with Professor Robertson. I'm going to, Jacques asked me to share one case, and I decided to add two cases, just to kind of go over my thoughts and my process of preparing for surgery and intraoperative management. So,
Keenan, sorry to interrupt you. If possible, before you tell us what you did, you could ask the speakers how they would handle the case. Then you show us what you did.
Excellent. So just I want to say a few things before I start. You know, one of the things that helps me in my preparation of orbital tumors and any tumor is obviously stealth neuronavigation. I like this mode of merging CT scan and MRI, where we can go back and forth, and it really gives us good opinion regarding tumor resection, tumor extension, and location. The other thing that is very important, which I learned from Dr. Al-Mefty many years ago, is to think about closure at the beginning. So very well-known technique of preparing perivascular, well-vascularized pericranial flap, and also harvesting fat from the abdominal fat tissue, as well as fascia lata as needed, because very often, as we know, we enter into the frontal sinus, ethmoid sinuses, and so forth. I share a philosophy with Dr. Caldwell that I do not do much reconstruction of the roof and lateral wall of the orbit, and I didn't see many problems with proptosis or enophthalmos. But if the tumor involves frontal bone or maxillary bone, I like to use, and I don't have any relationship with Stryker, but they do have orbital implants where Medport. They have, and others also have, where you can, the whole orbit comes and you can prepare it before surgery, and then when you remove certain parts of the frontal bone, maxillary, etc., you can pre-cut and tailor on the table next to you to put this orbital prosthesis as needed. I like to use 2 millimeter diamond, coarse diamond drill, and preferably if I can have permanent irrigation, which is important. And I will now just show this briefly, 2 cases that I prepared for this case. I added this case just to show the utility of pretemporal approach, which I use regularly when I go towards the orbit. And this is a 58-year-old gentleman with previous history of breast cancer and prostate cancer who presents with right-sided visual loss. And this is his MRI CT scan. I would like if Carl can just ask questions and kind of give me your plan with this patient. So previous history of cancer, 2 cancers, breast cancer and prostate cancer, very unusual in a man. And visual loss and this lesion in the area of the anterior clinoid and posterior orbit.
Yeah, you know, as you just look at it right away, I'd kind of say meningioma. I mean, you see kind of in the top middle picture, a little bit of a dural tail. There's a little bit, just seems like it's creeping around the anterior clinoid. I don't see hyperostosis on the CT. There's no pneumocystis dilatans, but it's not really over this the planum or the sphenoid. I mean, I guess it could be a met. That would be an unusual place to have a met go to, the bone of the clinoid. You know, I would bet if I saw this, I would say meningioma, and it's probably encroaching on the optic nerve as it goes into the optic canal. It's all superior lateral to the optic canal, so I wouldn't be thinking endoscopic endonasal. You know, this is the type of thing you could reach by the small approach Bill showed, you know, the lateral orbitotomy, but I would probably just do this one by just a small cariomal approach and go, you know, remove the tumor, drill out the clinoid, drill out the optic canal all the way out to the orbit and find out what it is. I see there's some enhancement on the bottom right. It looks like there's enhancement either in the optic canal or where the optic nerve should be. So that's probably the culprit.
And great opinions. One of the things that cautioned me that this may not be meningioma, you see the clinoid on the right side is smaller than on the left side, which kind of, you know, usually there is some hypertrophy if we are dealing with meningioma. It's not absolute rule, but it's most common. Bill, how would you approach this?
I think most of the points have been made. I think this is probably met given the fact that the clinoid's eroded a little bit. I agree with you. I mean, both breast and prostate can go to dura. I've seen it, and I've seen a met from a prostate in that location. My bet is met. I probably would do what Carl did, just a small frontotemporal, so you can come laterally and get the clinoid out properly. Take the dural tail, drill the canal out completely, and right out to the annulus to make sure he's well decompressed, and get as much circumferential decompression of the optic nerve as you can, because I'm not entirely sure. I can't tell exactly whether it's going into the canal there or not, but it may be, you know.
Yeah, it is involving canal. Here is the clinoid, then here it comes to the.
Yeah, so you can drill right out there and get all the bone off, and then open up I like to open it like 270-degree type thing, you know, to really get a wide opening of that.
Yeah, I mean, the only risk of that is just the hole into the sphenoid sinus, and if you don't have a pneumatized clinoid, drill away. You know?
All right, so I will just quickly go through. I agree with everything you said. I did look into the literature. There was no case of metastasis of an anterior clinoid area previously described. So, so this is approach, as you can see here, relatively small craniotomy, frontotemporal. This is roof and lateral wall of the orbit. I like to use, these are a couple of technical things. I like to use the stitches, which really beautifully serve as internal retraction. So I try not to use any retractors if I can help it. It's not always the case, but it helps tremendously. One of the things that Ali Krish does, he uses TUSIL to stop the bleeding. However, I love this gel foam powder. As you can see here, to me, it resolves almost all of my cavernous sinus bleedings, and I really don't need to use TUSIL. The other thing is, this is one of the rare cases when my direct irrigation did not malfunction, so I used external irrigation, but I'll show you on the next case how it works. So here is the splitting of the lateral wall of the cavernous sinus coming up, cutting the meningorbital artery. Here is the splitting of the lateral wall of the cavernous sinus, opening of superior orbital fissure. Here immediately I noticed that there is something weird, much like malignant tumor. You can see here third and fourth cranial nerves V1. You see that the layer is not perfectly glistening. There is some eating up of the dura. One of the other things, as you can see here, once we open the lateral wall of the cavernous sinus, frequently we release some CSF, which helps the relaxation of the brain before we even open the dura. Here is again utility of gel foam powder. And then here we start resecting the roof and lateral wall of the orbit. You can see here periorbita. And then we are reaching arterial clinoid here. You can see it nicely. I like to use this small rongeur until it, and you can see the beauty of pretemporal approach, that clinoid becomes this, superficial. It's right in front of your eyes and ready for resection. Here is opening again remnants of the superior orbital fissure wall. You can see here V1, V2, foramen rotundum here. You can see here some of the involvement already of the dura. Sometimes it helps to put a stitch and retract the stump of the meningorbital artery. Here again, I put the dural retraction stitch a little deeper. I like to use 1 millimeter Kerrison rongeur, and it serves me as a dissector. And then here you can see opening of the optic canal. You can see optic nerve completely, as Bill said, 270 degrees decompressed. And you can see here, now we start, this is optic nerve completely open. And you can see here that there is basically erosion of the bone, and tumor here comes out now. You can see here, and that this was proven to be a metastasis of the breast cancer in a man, which is extremely rare. Here is a final anatomy. This is a sphenoid sinus open, which I will plug either with the muscle or preferably with the fat tissue. This is carotid artery extradurally, which you can completely dissect and have proximal control here. This is second cranial nerve, third and fourth, V1 and V2, and then finally a whole picture after tumor resection of the anatomy. This is a postoperative scan showing the compression of the optic nerve, showing resolvement of enhancement, and then closure. You can see here the compression. The second case and the last case that I just did recently, about a couple of months ago. This is 36-year-old woman with left proptosis. You can see here. she had significant eye pain, sharp pain in the eye, and then significant visual field defect. As you can see here, she had left hemianopsia in her left eye. And I think there was similar case Carl showed, but I would like to ask him here, strategy and pearls, preoperative preparation pearls.
Yeah, I mean, I think, I agree with Bill Caldwell. You want to try to get out all of this abnormal bone on the CT. So I spent a lot of time just looking around. Is there anything I can't remove? Is there anything that can't go? If you look at the top left, a little bit of the bone of the orbital rim is probably okay. You're going to be drilling right up to that very edge of the orbital rim bone in the top left. Yeah, right as close as possible. But it just helps you have a perfect reconstruction if you leave the orbital rim. When I look at that image on the far right, the tumor is extending between the supraorbital fissure and rotundum, and there's little soft tissue in the lateral part of the sphenoid sinus there. So in this case, you're going to drill away all that bone around this whole supraorbital fissure, underneath it, a little bit between that and V2, all the way at the far right. But I would try to not get a big hole into the sphenoid sinus because it's hard to sew the dura in these cases closed in a watertight fashion, because very often you end up with optic nerve. The clinoid would be gone. You have the optic nerve there. You don't have a lot of good cuff of dura to sew to. So I try to leave at least an eggshell of bone along the sphenoid sinus there. You're going to be drilling back around the glenoid. You can drill down until you see some of the glenoid capsule or the TMJ, but I try to not. If there was tumor involved, I'd take it. I'm just looking at your dural extent. In the bottom left, you can see the tumor expanding and pushing the lateral rectus muscle in. So I kind of like to do the same thing Bill showed, where I do the whole, drill away all the abnormal bone, resect the dura, the anterior middle fossa, all the involved meningioma, and then do the part on the paraorbital last. And I also like to cut through the paraorbital, the very anterior-most part of the orbit, and then lift off this plaque of meningioma along with periorbit and peel it from anterior to posterior. Try to peel it off all the way back to the supraorbital fissure. I'm not sure if there's supraorbital fissure involved. It looks pretty close. The enhancing coronal image, second one from the bottom left, there's some enhancement kind of in the orbital apex. That's the area where it's hard to know if you got everything out or not. But
what would you tell this young lady before surgery? What are the chances? Obviously, she has significant visual loss in the left eye. What are the chances of regaining this visual loss?
I think it's pretty good. You can use an OCT to help predict that. If you're a neuro-ophthalmologist doing OCT, they can see how much optic atrophy, ganglion cell loss there is. But if it's not that bad, it hasn't been there for a long time, you can, get a lot of vision back.
Absolutely agree with you, and basically that's what I told her.
1 second, can I ask David? David, can you unmute your microphone? Just can you comment on the issue of reconstructing? You and I talk about it all the time when we're doing cases together. Reconstruction versus no reconstruction of the roof. You kind of saw, you heard two different neurosurgeons, really, Carl and Bill. Bill doesn't reconstruct at all. Carl oversizes the roof or lateral wall with a mesh. Can you just give us your perspectives on where you are with that?
Yes, I like to see restoration of normal anatomy as much as possible. I do vault the roof if majority of the roof is gone. Temporally, you have a lot more laxity as well. If the patient has noticeable proptosis, you need more room. It's almost like addressing a patient with thyroid ophthalmopathy, where there's a disparity with too much retrobulbar tissue and not enough room. So in reconstructing it after you remove the tumor in the greater wing, then I like to restore it, but vault out a little bit to create a larger cavity for that. Much of the residual exophthalmos may be related to scarring or residual intraconal meningioma that will not allow the eye to sink back in. And also sometimes the lateral rectus is infiltrated, again, creating a mass effect, minimizing the regression of the eye. So in general, I like to restore the roof, but provide some vaulting of the roof. So
Yeah. Okay.
Yeah, so just in the interest of time, this is preoperative, and then this is after opening. You can see here, I'll just come to the clinoidectomy. This is lateral wall of the orbit. And as Dr. Caldwell said, this is archaeology. I mean, this is, you see this giant anterior clinoid completely involved by the tumor, and basically we keep drilling. You see here what I was talking, constant irrigation with a little attachment to the drill. I think it probably helps a lot outcome of the vision. And I have now a series of about 10, 15 cases in the past couple of years where we had significant, well-documented improvement of the preoperative, either complete visual loss or significant visual loss, as we noted in this case. So anyway, I'll advance. Here you can see I use this 1 millimeter Kerrison very gently as a dissecting tool, as my Roton dissector. Here is now your optic nerve coming into view. You can see here, here is your optic nerve, and then working below between releasing 270 degrees around the optic nerve. Here is optic nerve. You can see that it was swollen, but now relieved and relaxed. And you can see here status post resection. I had a little bit additional resection to do here. Here is final removal of the clinoid. Here is the optic nerve completely freed. (270 degrees). And then at the end, we are resecting the dura that is involved by the tumor.
Kenan, to interrupt you, a question from your good friend Benedicto Colli from Brazil saying, if the hyperostosis reaches the glenoid cavity, should all the tumor be removed, leaving the condyle exposed?
Well, great question. And, you know, I would go on case by case basis. It's not like one size fits all. I would analyze how much is involved, what is the situation with resection in other parts, and basically go from there. So I would decide on case by case basis. I don't know what other panelists think.
I'll make one comment. You know, I heard about a patient who had no teeth, and someone did that, and the person fell on their chin, and the occipital condyle went up into the temporal lobe. And so some people have said if you have teeth and they'll hit each other, maybe your condyle won't go up into your brain. But if you don't have teeth, cut off the occipital condyle if you do that. So you just get rid of the joint essentially.
One of the things I want to draw your attention, how there is complete resolution of visual, almost complete resolution of visual field on the left side. And you can see here, this is, she came 2 weeks after surgery. Her proptosis significantly improved, just a little bit remaining, which resolved in the follow-up. So
thank you.
This is my presentation. Thank you.
Thanks, Kenan. Okay, Garni, welcome. I do not recognize you without facial hair, but I guess that must be you. So,
Yes, this is the COVID look. It's become
Nice.
very fashionable. The N95 doesn't fit with my beard, so I have to be clean shaven, which I haven't been since high school.
All right.
So thanks. All right, so I have one case here. I just want to see, is it sharing?
Yes, but you know, your voice has a lot of echo. I'm not sure if you can do anything about it. Probably not, just so that you're aware. There's echo in your room when you speak.
Let me turn off the fan and try one other thing here.
But we see your slides and fine.
Okay, this may help.
Okay.
All right, one brief case, and I had debated on a number of cases to present that were quite large, but I wanted to focus on a smaller case that I think is more about what approach to take and ask our panelists and our as was mentioned, our august faculty what they would prefer. So this is and I also want to thank my neuro-ophthalmology colleague, Dr. Howard Kraus, who has been very involved with the skull-based societies and is we work together on these types of operations, and we often operate together for these types of tumors. So this is a joint patient of ours, a 66-year-old woman who has a history of glaucoma that he's been managing for 20 plus years, but also started to develop progressive diplopia. On her exam, she had a left eye cranial neuropathy that was a partial, kind of mixed picture of a third nerve and sixth nerve paresis, but the pupils were reactive. This is her OCT that basically shows the effects of chronic glaucoma. It's very hard to tell if there's any monocular vision issues. You can see the left side really doesn't have any significant variance from the right side there. And this is her imaging. So CT on the top left and the post-contrast images, and I'll show you a couple more. Here's a fat suppression, axial and coronal sequences here showing the enhancing lesion. And then here is a coronal T2 that I'm just going to cycle through. And you can see this is the lesion here, of course, for the audience, and the optic nerve is running alongside it medially. So I think the question is, we have an idea of the differential diagnosis. Very likely this is either schwannoma or hemangioma, optic nerve glioma. I wonder if the faculty have any other thoughts on the differentials, and then what approach to take. I think we've seen the whole gamut of different approaches discussed today, and would love to hear everybody's thoughts.
Can I ask, David, if this patient had come to you, what goes through your mind regarding approaches? You're muted.
Well, the concern is that the confounding issue of glaucoma, whether this is indeed glaucoma. So it makes the diagnosis of optic nerve glioma in this age group would be very unusual.
Plus,
And
he thought it was quite separate from the optic nerve on those coronal MRIs.
yeah, for schwannoma in that location, certainly it's unusual. I don't think it's cavity hemangioma. It's a likely lesion in that location. So I think the rather than a diagnosis is what is a tissue. I think that were you able to get tissue to establish a diagnosis?
No, he hasn't operated. I mean, he hasn't. He's going to do it during his surgery.
Maybe.
Maybe.
What Dr. Howland or?
Yeah, I mean, I think that differential is correct, schwannoma or hemangioma. The way it kind of looks to me like a supraorbital fissure mass with eroded bones. So I kind of bet schwannoma. The question is, what nerve did it come off of? And I would hope it came off of V1, the frontal branch, but that's the question. You know, most schwannomas are sensory nerves, and if it's a V1 tumor, you could take it off. But of course, if it's on the third nerve or whatever, then you'd be hesitant. So the key is, can you figure out which nerve it's coming off of to help you decide what to do? You know, I would probably, in general, with things that go from the orbit, the supraorbital fissure to cavernous sinus, I like to do an orbital frontal and just a small one and take the orbital rim off just so I can follow the lateral orbital wall down. But you could easily do this by mini terional too. Either would be fine. No?
Bill?
Yeah, I think this is a benign lesion. It's well circumscribed, and it's got bone erosion. I would do a lateral orbitotomy on this. It's perfect for that. It's mostly under the clinoid. It's easily accessible and simple. That's what I would do. Yeah.
Yeah, I would agree with everything you've said, and quite frankly, I think people are going to assume somebody paid me to present this case because it's reflective of what you presented. I will also mention that the preoperative sensory exam was completely intact. She had no areas of hyposthesia or anesthesia around her orbit or her eye.
Do you have a CT scan?
There's one cut here I can show right there. It just shows some bony erosion at the posterior aspect there, and inferior to the clinoid and abutting the medial middle fossa there.
Garni, unless I missed it, there is one approach you probably haven't listed as a potential use is endoscopic transorbital. What do you think about that? Or did you list it? You put endoscopic endonasal.
Endonasal, is that what you mean? The endonasal transorbital, or?
No, I meant endoscopic transorbital, the Kim Mo approach from Seattle.
Yeah, so I kind of grouped that into the transorbital approaches, but yeah, so that should be on the list, endoscopic or microscopic.
Yeah.
So I just have a question though for Garni or for Bill, and that is, you know, if this is a nerve tumor and you do the lateral orbitotomy approach, obviously if it's a schwannoma, you're just going to follow the edges of the tumor, but how well can you work out where all the other nerves are to make sure you know what nerve you're operating in?
Yeah, so I think that's an important question. We do nerve monitoring for these operations, so we were prepared to have a nerve probe to stimulate any of the key motor nerves. The hardest one is the fourth nerve. It's very hard to monitor for, but it's easy to monitor 3 and 6. So I think that's one strategy. But you're right, it's a little bit challenging to do a nice wide dissection and identify the course of the third and fourth nerves, as was so eloquently shown through a transcranial orbital frontal approach.
Yeah, I think Carl, you can you just peel the dura off a little bit farther posteriorly and see where the nerve is in relationship to the ganglion, and the tumor is going to be in the way of you visualizing 3 and 4 because it's quite superior in the supraorbital fissure there. But you'll be able to find probably a window to get in there and debulk it, and then as you debulk it, you'll be able to see where the capsule is attached. You know.
Yeah.
That's the way I would go at it. So.
Yeah, and I have to thank Dr. Caldwell's experience with this, because we did reference your publication on choosing the approach. You know, we typically had been doing a larger orbitotomy, taking the roof of the orbit as well as the lateral wall to get to these types of tumors, and that left a reconstruction issue that I think have nicely discussed today. So we've increasingly looked at the pure extended lateral orbitotomy approach that you demonstrated. And it's a very appealing approach for small tumors because, as you said, you don't have to manipulate the temporalis muscle. There's no brain retraction. and you have this direct shot to the, and a very anterior shot to the pathology. And of course, one can take it farther back if necessary, as you showed, to cavernous sinus or Meckel's cave. This is something we just did a quick dissection in the lab just to verify. One key difference that that we had compared to your dissection, Dr. Caldwell, is that we did not plate the bone. So instead, we used kind of a keystone type of a cut with the osteotomes, so that the bone would just fall back in, and we just kept the periosteum intact with a linear incision so that we could sew the periosteum at the end. That allowed for a nice reconstruction. But here you can see the capsule of the, I apologize, I don't have a video for this, I'm sorry about that. But here you can see the capsule of the tumor, and this tumor did turn out to be schwannoma, which is very fortuitous for us. The nerve, the capsule did not stimulate for 3 or 6, but we were able to peel it out of its capsule without much stimulation, without much manipulation, and it basically fell out. And it was a very satisfying case for this. And this is the postoperative scan that demonstrates basically a gross over section. These are 2 years out now, no recurrence. And interestingly, her double vision did recover pretty quickly, and she had a nice cosmetic result with just a little bit of an incision. You can tell at about 2 years, but it's very hard to tell. You really have to know that she had surgery to tell the difference there. So that was it, really. I just was really more interested in approach selection for that, and you know, it would be good to hear if anybody would have done an endoscopic transorbital approach or not on that, but that's the way we have opted to do it.
Great. Any comments from anybody? Otherwise, great. Thanks, Garni. Great case. Let me ask a couple of questions from the audience before I let you guys all leave. Questions about use of angiography and venous timing before approaching the, maybe it was in reference to the large invasive meningiomas. Carl, do you have any use for angiography for extensive skull-based meningiomas?
Pretty much I don't do it. The only ones I would do would be a giant, orbital one with huge flow voids that I thought saved me a lot of bleeding on the way in, but I pretty much hardly ever embolize, hardly ever do angiograms.
Okay, do you, I guess I'm not, maybe the audience member didn't mean that, but I'll turn the question for more posterior tumors, you know, where you might be considering petrosal approach, or would you do it to understand the sigmoid or transverse sinus or vein of Labbé or something like that?
Yeah, I mean, usually I just study the MRI and look at the, you know, if you have 1 millimeter slices, you can kind of follow every vessel. If I don't understand it after looking at that, I might do one occasionally. I'd say more often if I have to do a balloon test occlusion, I do an angiogram, but most of the time on high quality imaging, you can figure out what's going on.
Bill, what's your wisdom on angiography for meningiomas pre-op?
Yeah, so there's sort of, the way I think about it is I think about the arterial side and the venous side. And I agree with Carl on the arterial side. You can usually glean the information from a CTA or an MRA or an MRI and just see the enhanced pattern and see where the arteries are. And I never use preoperative embolization anymore. I've been burned with that. And for petroclival and posterior petrous, there's not much to do anyways because it's Bernasconi and Castaneri. But I do study the veins. And Jacques, you and I have gone through this before, and we've published an issue on Focus on this. It is a confounding issue, the veins. And the older you get, the more experience you get, you realize that you don't understand it and you can't predict it. And I was struck by Kawase at the World Academy, Jacques. You know, he always talks about doing anterior petrosectomy for everything.
Yeah.
And stuff that I would just do a retrosig on. And then he said, oh, by the way, you know, some of these cases have a lot of venous drainage through Firmino Valley, right? And you put a lot of veins at risk, you know, if you cut subtemporal, or, you know, if you embarrass the vena vulvae or the transverse sigmoid junction. And so he now, he says before he does any anterior petrosal approach, he does a venogram or an angiogram with a venous face to see the venous drainage, because some people can have a dominant drainage, especially with cavernous sinus tumors. Tumors extending the cavernous sinus, they can have tributaries that normally aren't the main conduit, but maybe detours, and you don't want to embarrass those. So that being said, yeah, I'd look at the veins very carefully.
Yeah, yeah. Like to pose a second question, radiation therapy post-op, particularly for unplaque meningiomas. How about anybody on the panel or the speakers? When do you use radiation therapy, let's say on a grade 1, WHO grade 1 unplaque meningioma? Would you use it if you've not taken it completely out, or would you watch it?
I would say I would always watch it and see what happens. And, you know, I have gamma knife some in the lateral rectus muscle years later, but I would just watch it, see what happens. Those grade 1.
I would also watch it, Jacques. I don't think, especially, you know, if you don't have any signs of grade 2 or higher grades, you don't know, you know, you really learn behavior of the tumor by observation in the follow-up period, carefully analyzing postoperative images. And if you leave some residual, you see how they behave and get pretty good feeling about this remnant or residual part. Now, having said that, I have seen a case or two when at some point tumor decides to explode. I think Dr. Al-Mefti and Dr. Caldwell did publish something about this, albeit after gamma knife radiosurgery, but overall I follow it. And by the way, Dr. Caldwell, can you comment on that? I found that fascinating, how the tumor, Dr. Al-Mefti and you have been showing that after 20, 30 years, some of the meningiomas go absolutely crazy, explode, and there is no treatment.
Sure. Yeah. So yeah, Jacques, as far as the question from the audience, I would watch, unless it's a case like a cavernous sinus meningioma that I've watched already and it's growing, and I've done subtotal resection, and then I would just go to radiation for that if you've watched it grow already. But I agree with them completely. Yeah, I think this is empirical. I'm not a big fan of radiation in general, but if you follow these patients that have been radiated, you need to follow them for a long time, because we've had some late recurrences. Like I had a nurse that was 15 years out from a gamma knife. And then when the tumor, you know, starts to recur, it can be worse and it can grow fast. And we looked at the growth patterns of these tumors when they did fail, and it was much higher than the initial growth ever was on these patients. So fair warning. I don't know whether the radiation's inducing any further genetic changes in the tumor, but I've seen that after surgery too. You know, after multiple surgeries, we've all witnessed the tumor increasing in grade and speed. So I think it can happen to any tumor. So.
Last question from the audience. Maybe I'll ask David first. A question about the favorite reconstruction material to rebuild the skull base or the orbit. Is it titanium? Is it methyl methacrylate, bone cement? Is it hydroxyapatite? Well, David, what do you and most oculoplastic or orbital surgeons think about when they think what's an ideal reconstruction material to rebuild the orbit?
Well, I use a titanium mesh, and then hydroxyapatite mesh on top of that. So, but you need to have a structural support of the roof. So the titanium mesh, I think, is the best material.
Carl, I enjoyed watching you stuff that muscle in those fistulae. You really, that's amazing. You redid what Dwight Parkinson did, I don't know how many decades ago, but it clearly works. I mean, I've done the same thing, but not with muscle. When you have no access, we've done intra-op onyx through sphenoparietal sinus, craniotomy, so forth, access. But it's interesting just keeping it simple with the muscle.
Yeah, I was thinking about doing that and cannulating these spaces and putting angio, then get a, intraoperative angio, and I'm thinking that'll take twice as long as just going there and packing it. But the only thing I would add about reconstruction,
Yes.
that MedPor Porex orbital implant is great if the orbital rim's involved. So if that has to go and you want to reconstruct that, the right and left side orbital rims pre-made are pretty good.
Yeah. Anybody else has any comments before I let you go to dinner or yeah?
My only comment is that I've given up methylmethacrylate years ago because they all get infected and I can't stand the stuff. And then,
it's probably carcinogenic, the goddamn smell that it gives.
I know. And we've used MedPor for years and years, and you can actually put it next to fairly contaminated spaces and you get away with it. So
yeah,
if it's non-load bearing, I use MedPor. If it's load bearing, I use titanium mesh.
Okay. Yeah. Well, this has been tremendous. I love the multidisciplinary aspect. David, thank you for sharing 2 hours with neurosurgeons. We're not as bad as I am, so you can see there are much nicer people than me in neurosurgery. So guys, thank you so much. Have a wonderful evening. The audience, thank you for being here, and I'm sure they all loved it.
Thanks, Jacques.
Thank you.
Thank you, David.
Thanks for organizing.
Thank you.